Welcome to this revision video for medical students on the topic of dementia. Much of the information is adapted from the book Dementia in Clinical Practice, a Neurological Perspective by A.J. Lana. If you want more information on anything discussed in this video, that would be a good place to start. See the further reading slide for more details. There is a practical two-stage approach to assessing patients with possible dementia. First, decide, is it actually dementia? Second, determine the cause of the patient's dementia. We'll cover the first step in this video. The second part of this presentation goes into diagnosing subtypes of dementia and is linked in the description below the video. What do we specifically mean by dementia? I'm sure you already have a good idea, but the World Health Organization's definition includes a lot of useful clinical information. So we'll start there. First, dementia is a syndrome rather than one homogeneous disease. Dementia usually has a chronic or progressive nature. You may encounter the term reversible dementia, but this generally refers to cases where a patient has signs or symptoms of cognitive decline which are actually secondary to a non-neurodegenerative illness. So, broadly speaking, dementia is chronic or progressive. Dementia is characterized by the deterioration of cognitive function beyond what might be expected from normal aging. In other words, it's not normal to have dementia with age. Some cognitive changes happen as we get older, but dementia is not the product of a healthy aging brain. Somewhere in between normal cognition and dementia lies the concept of mild cognitive impairment. If you have cognitive problems which have a big impact on your life and cause functional impairment, that is defined as dementia. If, on the other hand, you have cognitive problems but get by okay without much additional difficulty, that is mild cognitive impairment. Finally, in dementia, consciousness is not affected. This separates dementia from states such as delirium. We'll touch on epidemiology very briefly. Figures from the Alzheimer's Society in 2014 suggest an incidence of around 225,000 new cases of dementia per year in the UK. Prevalence is estimated at 850,000 patients at the moment in the UK. Of these patients, 40,000 were under 65 years of age and so fall into the early onset dementia bracket. Incidence of dementia is projected to increase in the future, largely due to the ageing population. However, the increase in the number of cases does not appear to have a linear relationship with population ageing. Protective factors such as better management of cardiovascular disease and improved education may cause a fall in the overall incidence of dementia. How do we determine whether a patient has dementia? Dementia is ultimately a clinical diagnosis. There is no one diagnostic test for the condition. NICE guidelines say that clinical assessment should include the following steps. Take a history from both the patient and an informant if at all possible. Perform cognitive screening and a mental state examination. Perform a neurological examination. Some dementia subtypes are associated with specific signs on examination, but generally a normal neurological examination doesn't rule out dementia. Request investigations as appropriate. And finally, before diagnosing dementia, NICE recommend that you review the patient's medication and minimise the use of drugs which could affect cognitive function. When assessing for possible dementia, you can focus your history on 6 main questions. What memory problem is being reported? Ask for specific examples. Dementia is more likely if the patient tends to frequently repeat the same questions or comments. Why has the patient presented now? Has anything happened recently to prompt this consultation? Patients may have had a recent episode of delirium, which can be associated with early dementia. Some patients are worried because they have a family history of dementia and are seeking reassurance. When did the memory problem start? Age at the onset of cognitive impairment is relevant. Statistically speaking, memory problems which start at an older age are more likely to have a pathological cause. It's also important to know if things are getting worse over time. A progressive decline in cognitive function over a year or so is more concerning than many years of relatively stable forgetfulness. How have the patient and their family coped with the cognitive problems? If you can explore whether home life and the patient's occupation have been affected, you can better differentiate between dementia and mild cognitive impairment. Where do the problems occur? In its early stages, the symptoms of dementia may be manageable at home, but can become worse in less familiar situations. And finally, who actually reported the memory issue? Patients who attend alone to discuss a self-reported memory problem and who can offer clear examples of memory lapses probably do not have an organic cognitive impairment. Dementia is more likely if the patient is brought in by concerned family members. Perhaps when family members give examples of memory problems, the patient with true organic dementia may report no memory of the event or might dismiss the examples as trivial concerns. Remember to consider the following related issues in your assessment. Mood. Mental state examination should be performed to exclude depression and psychosis, which can present as pseudo-dementia. These conditions can develop secondary to dementia, but they can also exist independently. Sleep disorders. Poor sleep can have a huge impact on cognitive function. Look out for conditions such as obstructive sleep apnea and restless leg syndrome, for example. Sleep disorders can also be part of a dementia syndrome. Delirium. This is an acute confusional state which can develop rapidly over hours or days. Delirium involves a change in the patient's level of consciousness and cognitive function, which can fluctuate over time. You can have both delirium and dementia at the same time. In fact, having dementia increases your risk of delirium. Generally, though, you should try and exclude delirium before making a diagnosis of dementia. Next, we need to formally assess the patient's cognitive function. This should be done with a cognitive screening instrument. There are loads of these available, and they are all designed for slightly different contexts. If you just want to know which test to use and when, follow the flowcharts in this presentation. There's also a table at the end of this video with links to free online versions of each test where available. So, let's say you're assessing a patient in primary care. Have they brought a relative or friend who knows them well to the appointment? If they have, you can use either the GP COG or the 6CIT. Both of these cognitive screening instruments are designed for use in primary care. If they have attended alone, you should use the 6CIT. Secondary care is a bit different. You should consider whether the patient might have mild cognitive impairment. If this is a realistic possibility, use the MOCA because this test was designed specifically to separate mild cognitive impairment from dementia and from normal controls. If you think mild cognitive impairment is not a likely diagnosis for this patient, then you can use the MMSE when under time pressure. Ideally, though, the MOCA would still be preferable. On to investigations. NICE guidelines say the following blood tests should be performed as routine for dementia to exclude reversible conditions: full blood count, urea electrolytes, calcium levels, blood glucose, liver function tests, thyroid function tests, vitamin B12 and folate levels. Additional non-routine investigations should only be performed as clinically appropriate. These include midstream urine culture to exclude a urinary tract infection, chest radiography to exclude pneumonia, serology for syphilis and HIV, ECG to exclude things like atrial fibrillation in the context of vascular dementia, and neuroimaging. MRI for diagnosing the subtype of dementia is typically arranged by specialist services. However, a CT scan can be helpful to rule out other causes of cognitive impairment. Management of dementia. The second video goes into specific management for dementia by etiology. The main point for those outside of a specialist service, however, is to offer support and refer to a memory clinic. If the patient's dementia is rapidly progressing or involves neurological symptoms or signs, refer urgently to neurology. Patients with a diagnosis of dementia should be advised to stop driving and to contact the DVLA for assessment. If there are no significant issues with memory or attention, they might be allowed to continue driving on a yearly licence. However, you cannot drive on a Group 2 licence with a diagnosis of dementia. Memory clinics can offer diagnostic support, access to neuroimaging and treatment advice. Note that NICE guidelines say cholinesterase inhibitors should only be started by a specialist. Avoid antipsychotics for management of behavioural and psychological symptoms if at all possible, because they can increase the risk of stroke in elderly patients. Management of mild cognitive impairment. Patients with possible mild cognitive impairment should also be referred to a memory clinic for long-term monitoring and early detection of progression. Patients with mild cognitive impairment can continue to drive on either type of licence if safe to do so, and do not need to notify the DVLA. If their condition leads to issues with driving, they should stop driving immediately and notify the DVLA, who will assess them individually. To summarise, in diagnosing dementia, you have to address each of the following stages. Is there a possible cognitive impairment? No impairment means no dementia by definition. Have you excluded any possible reversible or non-organic causes for the cognitive impairment? You have to exclude non-organic causes of cognitive impairment to diagnose dementia. However, perhaps counterintuitively, you can diagnose mild cognitive impairment even if the cause is non-organic. If the cause of cognitive impairment is potentially reversible, the patient should be followed up for improvement of cognitive function and reassessment. Is there significant functional impairment as a result of the cognitive issue? If this is present, the diagnosis is probably dementia. If there is no significant functional problem, this would instead be mild cognitive impairment. Thanks for watching. We hope this was useful. In the next video, we cover diagnosis of dementia by etiology and go into more detail with examination, investigations and management. Please contact me at alexwojtowicz@doctors.org.uk if you have any questions or comments related to this learning resource. Here are some links to copyright-free cognitive screening instruments. These links are also in the description below the video. Many thanks to Dr. A.J. Lana for supplying me with a copy of his book and allowing me to adapt so much of this talk from his work. Any mistakes in adapting the material are my own. Thanks also to Dr. Owen Pickrell for supervising this project.